Good afternoon. Thank you for joining us. My name is Trish, and I will be the moderator for today's Ask the Expert webinar, ADHD and the AAP 2019 Clinical Guidelines. Today's webinar is brought to you by CHADD's National Resource Center on ADHD. Our mission is to improve the lives of people affected by ADHD. We will start with a presentation, followed by the opportunity for you to ask our expert your questions. At any time during the presentation, you may submit your question into the question box. If we are unable to get to your question, please feel free to contact CHADD, and one of our health information specialists will provide you with information and resources. We are available Monday through Friday, 1 to 5 p.m. Eastern at 866-200-8098 or at customer_service@chadd.org. You can also find us on our website at chadd.org/NRC. And now I am pleased to introduce today's expert, Dr. Witznitzer. Dr. Witznitzer is a graduate of Northwestern University School of Medicine. He trained in pediatrics and developmental disorders at Cincinnati Children's Hospital and in pediatric neurology at Children's Hospital of Philadelphia. He then did a National Institutes of Health funded fellowship in disorders of higher cortical functioning in children at the Albert Einstein College of Medicine in Bronx, New York. Since 1986, he has been a pediatric neurologist at Rainbow Babies and Children's Hospital in Cleveland, Ohio. He is an associate professor of pediatrics, neurology, and international health at Case Western Reserve University. He has a long-standing interest in neurodevelopmental disabilities, especially ADHD. He is on the editorial board of Lancet Neurology and Journal of Child Neurology, and lectures nationally and internationally about various neurodevelopmental disabilities. And with all that said, I will now hand it over to Dr. Witznitzer. Thank you, Dr. Witznitzer.
Good afternoon, and thank you everyone for joining us. It's a pleasure doing this with you. As was stated here, the topic for today is the recently released 2019 American Academy of Pediatrics Guidelines for the diagnosis and management of ADHD. These came out in late September. In addition, we've also added a few slides dealing with the Complex ADHD Guidelines released by the Society for Developmental and Behavioral Pediatrics earlier this year. They were just published within the last month and released sometime end of January, beginning of February. Just my disclaimer, as usual, I'm a member of the Board of Directors of CHADD, and I'm also the co-chairman of CHADD's Professional Advisory Board. I have no connections or interests in dealing with any of the pharmaceutical industry involved with ADHD or actually with anything else. What is ADHD? This is just a quick primer just to back up things for you. It's the most common behavioral disorder of childhood, which, of course, if you're a parent or of a child with ADHD or a person who has ADHD, you probably recognize this by now. The numbers that have been proffered depending on where you look around the world, but on average, it occurs in about 7, maybe to 10% of the population. About half those individuals continue to be symptomatic as adults. It's more boys than girls in the childhood years, but interestingly, it's about equal in terms of male and female representation in the adult years. And reasons are varied and in part deal with temperament, personality, and predispositions that occur between boys and girls. It is an old disorder. In 1902, it was described as a morbid deficit of moral control. And actually, if you read the criteria for that condition in the publication that came out, it basically describes an individual with ADHD. It was erroneously labeled as minimal brain damage as part of the general picture of the minimal brain damage population, in part because it was thought to be that something had to happen to the brain, and it was done in conjunction with language-based learning problems and problems with motor coordination. Later, when studies were done showing that no overt damage was present, it was called minimal brain dysfunction. Since the Diagnostic and Statistical Manual of the American Psychiatric Association has been published, ADHD has been present in some form. It's been called hyperkinetic syndrome, ADD with or without hyperactivity, which is really where people have gotten the idea of I have ADD versus I have ADHD. They're really synonymous terms, and you'll understand why as we go on in this talk. And since 1987, it's been called ADHD. Within the 1994 and the 2013 DSM criteria, basically describing similar conditions, the American Academy of Pediatrics came out with guidelines for the management approximately 10 years ago or so, and then updated them last year because of issues that had to be covered, and we will discuss those in a few minutes. Now, in the Diagnostic and Statistical Manual, the classification of ADHD changed into the category of a neurodevelopmental disorder, acknowledging the fact that while it's present in childhood, it really is a lifespan condition that affects individuals. They also changed age of onset criteria in terms, it was described that you had to be symptomatic by age 7-8 years. But now they said you have to be symptomatic by 12 years. That's fully symptomatic. If you really take good histories, you find out that individuals almost always show features of it before that time. They also offer diagnostic criteria for adults. They basically differentiated between the different subtypes and explained why and showed how they differed from each other. They basically discussed issues about the severity of features and therefore the functional impact that ADHD can have on individuals, where you may have 10 individuals with a diagnosis of ADHD and 10 different levels of functional impairment depending on what areas in their lives are actually being impacted. They also addressed the issue of where information was obtained from regarding the diagnosis of ADHD and basically made it more widespread, where it wasn't just home and school, but also other family members, the workplace, and other places within the environment in which individuals with ADHD may be located. And then, one of the important things that occurred in the most recent DSM-5 categorization is they did what all of us knew should be done. They said that, yes, even individuals with autism spectrum disorder, in this case, pervasive developmental disorders, which are synonymous terms, even those individuals can have ADHD, something that all of us in practice knew for years before that, but now they just basically officialized it, if you want to think of it that way. Now, when we look at the diagnostic criteria, one, it has to have a negative impact on your functioning for your developmental level. That means if I'm 10 years old with the intelligence of a 10-year-old, I should have the attention span of a 10-year-old. If I'm 10 years old but I have the intelligence of a 5-year-old, I should have the attention span of a 5-year-old. And of course, there's the diagnostic criteria, which includes inattention, motor overactivity. I don't call it hyperactivity because it ranges anywhere from being fidgety to bouncing off the walls, ranges anywhere from actual motor movement to even verbal overactivity, which means talking too much, as well as impulsivity, onset before age 12 years, present for a long period of time, not just as an acute reaction to some life stressor, being symptomatic in multiple settings, and it's affecting your functioning, whether it's social functioning, academic functioning, or work functioning, it is having a negative effect. When we look at the inattention criteria, there are 9 criteria. 6 of 9 have to be met by children. 5 of 9 have to be met by the older adolescents and adults, with the expectation that most of the time the adults will have more of these, but adults may have adjusted to some degree and therefore may not be as overtly symptomatic, although if you really look at them carefully, you'll find out, like the children, adults are not efficient in their functioning, which is the impact of the ADHD. They can't get things done efficiently. I'm not going to cover the criteria. That's not important for today's talk. In the same way, the hyperactive impulsive category ranges from being fidgety to on-the-go or driven, and in this as well as in containing impulsivity criteria such as blurting out answers, interrupting, not waiting your turn, and deliberately not putting in criteria that deal with some behaviors that might be confused with other psychiatric disorders. And here again, for children, 6 of 9 of the criteria. For older adolescents and adults, 5 of 9 of the criteria would make it sufficient to be diagnosed with the disorder. Now, there are other associated features that are consequences of the ADHD and also impacted by other factors such as other mental health issues, temperament or personality, and life events that surround the individuals. We know because of the ADHD, they may have a low frustration tolerance and easy blow-up and impulsivity, leading to tantrums. We know from dealing with these children and with the adults, they can be bossy and stubborn, even almost like in an irrational manner, insisting that things be the way they want and therefore nagging you when they don't get what they want. And it leads to self-esteem issues as well as issues interacting and relating with others, culminating in rejection by your peers if your behavior is so off base that it cannot be tolerated by them. It impacts academic and work achievement. It impacts doing your tasks, so therefore you're erroneously labeled as lazy or irresponsible. And it impacts the family, which can lead to a lot of resentment and antagonism within the nuclear family unit. One of the changes in the DSM-5, which is also mentioned in the diagnostic criteria that were brought out by the American Academy of Pediatrics, is how we're using the actual labels. We know that ADHD is the category, but depending if you meet criteria for hyperactive impulsive, inattention, or both, you can be subcategorized into one of these 3 groups. But that subcategorization only represents your status at this time. For example, preschool children, who really are not that easy to measure regarding attention span because they all have so much short attention spans, can usually get categorized as hyperactive impulsive, but as they get older, for instance, 9, 10 years old, they may then meet criteria to be categorized as combined type, and when they get to adulthood, as the impulsivity and the motor overactivity diminishes, they get categorized as being predominantly inattentive type, are all the same individual, but at different points in their lifespan. And therefore, these are specifiers of your current status, not labels that will follow you throughout your life. Now, the ADHD guidelines put out by the American Academy of Pediatrics were basically just some slight modifications of changes that occurred in the 2011 guidelines, some of the topics of which I've already covered here. But they also split out 2 groups that they emphasized. They discussed the preschool population and making diagnosis in the preschool population and the adolescent population, and I'll cover some of those points. They also focused on comorbidities, and their report was supplemented and supported by the report from the Society for Developmental and Behavioral Pediatrics on complex ADHD. Now, the reasons were, if you look at the issues of comorbidities, and comorbidities are other problems that are occurring in conjunction with ADHD. I'll give you a list of those later on. But it's other problems, whether they're mental health issues, such as anxiety or a mood disorder, whether they're physical problems, such as developmental coordination disorder, which means problems with your fine and gross motor skills, whether it's a movement disorder such as tics. All of these are conditions that can accentuate and aggravate the features of the ADHD and make it more difficult to manage. And therefore, it's important to recognize that they're there, and sometimes that the ADHD is also behind them. The reason for this is because these areas, whether you're a preschooler, an adolescent, or you're having the coexisting conditions, are challenges both to the children and to the families. For example, teenagers frequently are challenges to their families just in their regular states. With ADHD on board, it can accentuate and heighten the potential conflicts that can occur between the teenager and their primary caregivers. Also, there's a need for making sure that we know how to identify features of ADHD in these age ranges, and also to identify the coexisting conditions, which are the algorithms that are there, and the clinical resources are making sure that there are people who know how to do it. And then thirdly, the issue about barriers to implementation, which means how can we easily take these guidelines and apply them in everyday life, or what is there that's going on that's stopping us from doing it? So the impact. The goal for the impact is these individuals should spend more quality and positive time with their families. Also, the impact is on the primary care provider that there should be management with schools and other individuals who are involved. Schools, coaches, employers, that everyone knows what to do with these individuals, and it's a coordinated effort in order to help them learn the appropriate behavior patterns in order to manage with their ADHD and be successful in life. It has to be coordinated care, not fragmented. So the right hand has to know what the left hand is doing. And we also have to recognize that there's limited access to mental health caregivers in many environments. So the pediatrician should be able to identify problems that are present, co-manage some of the simple problems. For instance, the American Academy of Pediatrics has been telling pediatricians for years that if there's uncomplicated depression, they should be able to identify it and co-manage it with the appropriate mental health specialist, usually a therapist. If there's anxiety on board, most of the toolkits, which means the resources available to the physicians that help them with the ADHD individuals, also have checklists that help them identify coexisting anxiety and then intervening for it. And then they should know how to seek help whenever they get to if they get to a point where the child or young adult is still having issues, that they know who to ask for help and can get it done. Now, with the American Academy of Pediatrics guidelines, they have various levels of recommendation. The strongest is that their recommendations are supported by well-designed studies, usually randomized studies, or randomized control studies. So you have two groups. No one knows who's in each group. No one knows what treatment is necessarily implemented. There may be a sham treatment in one group, which means not the real thing, but something that looks like the real thing. And the people who are scoring it don't necessarily know who's doing what. But it can always go down to the lowest level, which is the lowest good level. The lowest good level, which is expert opinion, occasional case reports, reasoning from first principles. And not only are we looking for is there strong information about the intervention, but also what does it enhance in your functioning? Just because you intervene does not mean it's going to make a major change. So I can do a study in which I identify that a change occurs, but it might be such a small change that in practical situations, it really doesn't have an impact on what you're going to be like 5 years from now. So while it still has a positive effect, it's not a positive effect that's really going to be meaningful for you. Many of the guidelines that were put together here were based on the higher tiers, but some of them were also based on expert opinion, including, for instance, recommendations for some of the preschool children. So here's basically some of the recommendations that the American Academy of Pediatrics came down with. One, the DSM-5 criteria, the Diagnostic and Statistical Manual criteria that I just reviewed, are the ones that should be used for making the diagnosis. Not because someone tells you, not because you gestalt it or just have the feeling or the feeling that it's there, but it's really there. Neuropsychological testing does not necessarily need to be done on every child with ADHD. There are situations when you need it, when you suspect there's underlying learning problems, when you're not quite sure what's going on, and is it ADHD, could it be something else? For instance, individuals with reading difficulties will not pay attention quite well in classes that require a lot of reading. And this kind of testing can differentiate between ADHD, reading difficulty, or both. Also, the DSM-5 criteria with appropriate modifications for developmental level are applicable to the preschool population. That's what the American Academy of Pediatrics stated. Now, for teenagers, for the adolescent population, there are some challenges. There are more teachers involved, like in the high school setting, and in my clinical experience, I can tell you that I get better feedback from the teachers of the younger children than I necessarily get from the teachers of the high school children, although that is also changing. When you're getting feedback from many different teachers, you may find out that the behavior is subtly different in certain classes compared to others, depending on what the work demands are. Number two is parental input as to what the children are doing is not as strong because parents aren't keeping an eye on their teenager as much as they do on their 6 and 7 and 8 year olds. Number three, is that as individuals with ADHD get older and going through the teenage years, the hyperactive component, the part where they're not being able to sit still, when they're bouncing off the walls, fidgeting, getting up and walking around, basically may reduce itself. It may reduce itself to the point that they fidget in their seat, they can't keep their hands to themselves, keep their hands busy. Or if you ask them, they'll say, I feel an inner restlessness. I feel as if I have to move. But if you don't ask those questions, they may not tell you. One of the problems is asking teenagers to do self-report has been shown in studies to not always be the most reliable thing. If a teenager reports something, get corroboration from a parent or a teacher, because it may be that the teenager is downplaying any problems that are present. And teenagers have a greater risk of coexisting conditions. This is the age where anxiety disorders become more prominent, when mood disorders become more prominent, when issues with self-esteem may become more prominent, simply because of the normal changes that occur in the pubertal years and issues with peer relations. Now, for the management issue, the recommendation was that it has to be done in looking at in the long term, not just as a one-shot deal. We're not looking at treating an ear infection with 10 days of antibiotics and we're done. This is something that requires years and years and years commitment with an eye towards the adult years where at least half this population will continue to require intervention. So it has to have a chronic care or medical home model where someone has to basically be the official in charge. The American Academy of Pediatrics is pushing that the pediatrician be that way, but it doesn't always have to be that way. There can be another physician or another care provider who basically is the coach / quarterback and calling the shots and coordinating the team effort. We have to recognize that teenagers are not always compliant. We know in studies that have been done that the use of medication tends to drop off. In other words, the percentage of individuals who continue to take medication drops off as the individuals get older. And we have to recognize that when that happens, but they're still symptomatic, we have to offer them alternatives if they don't wish to be on medication. There's also long-term risks that are associated with ADHD. We know that in the adult years, there's actually a shortening of life expectancy. On the average, I think, of 6 to 9 years, they have a shorter life expectancy. This is a combination of risk-taking behavior, the mental health conditions can be associated, as well as developing other medical disorders and not having good management of those medical disorders. That is a topic which I think has been addressed in a previous webinar. Now, for treatment, we have to maximize the use of the interventions we have. For the preschool years, similar to what the Centers for Disease Control recommend, the AAP Guidelines state that parent training or a behavior classroom should be first step. Now, we recognize there are some children who are so symptomatic with their ADHD that is probably not feasible, that in conjunction with the behavioral and educational intervention, you also have to start medication. But in many children, the use of medication should be a second tier and not a first tier issue. And if you need to use a medication, the recommendation is to use methylphenidate or a Ritalin product, not because it's superior to the amphetamine or Adderall products, but because we have more data telling us that it works for this population. It works, but interestingly, it doesn't work, you think of it as this way, as strong as it would in the older ages, and it tends to be associated with a bit more side effects in that regard. Now, in the later years, after the preschool years, the best intervention is what's called multimodal therapy. Medication for treating the core symptoms of ADHD, the inattention, the hyperactivity, the impulsivity, and the use of behavioral and educational strategies to develop good habits for learning, good habits for behavior, good habits for functioning on a day-to-day basis. The American Academy of Pediatrics also does not recommend pharmacogenomic testing. For those of you who do not know, pharmacogenomic testing is basically a test that purports or claims that it can identify a medication that may be more effective for that individual based on how that individual will break the medicine down or metabolize it. In other words, process it in the body, whether it's absorption or how it binds to sites or how it's metabolized or broken down. This is based on looking at genes and looking at differences in specific genes associated with either ADHD or with the medication and how it's processed, and stating, is this individual going to be able to handle this medicine appropriately? This information has been used for the management of conditions such as depression, but even the most recent studies that have come out, there was one that just came out recently that reviewed all the medical literature and said, while this is an interesting area, we do not have enough information to really make the testing that's available in the market today truly functional and appropriate and useful on a day-to-day basis, and therefore it's not recommended. Now, in the teenage years and in the adult years, obviously, you have to monitor for diversion of the medication. Instead of the medication being used to help with ADHD, the individuals may be selling it or giving it to other people, or in the very small number of situations, it may even be abused by those individuals. Many medical centers nowadays for the adult population recommend and also for the teenage years, recommend periodic drug screens as a two-parter. One, to make sure they're still taking their medication, and two, to make sure that they haven't developed a substance use disorder, which means they're not abusing drugs. And of course, treatment to maximize the use of whatever we're doing implies that we have to have appropriate school programming. I know that is easier said than done, but there are effective ways for these individuals to be taught and to learn. And these are things that we have to expect from our schools, and if not available, that they can improve. Now, the Society for Developmental and Behavioral Pediatrics came out with their Complex ADHD Guidelines, and what they defined as complex ADHD was ADHD occurring in the preschool years, under age 4 years, and yes, there are 3-year-olds who are symptomatic. I've taken care of quite a few, and I can tell you these are individuals that you can clearly identify as needing an intervention. All are individuals older than 12 years of age at the time of their presentation with their full symptomatology, not just someone who was 8 years old when we first diagnosed them and now they're 14 years old. But they didn't seem to be symptomatic until this specific age. Number two, a complex ADHD is one with a coexisting condition. I will show you a list. It also has a moderate to severe impact on daily functioning. It really has a negative effect and causes functional impairment on a day-to-day basis for the individuals with the diagnosis. There also may be an uncertainty. There's something affecting attention. There's something affecting impulse control. There's something making the individual fidgety. Is it ADHD or is it something else? And then lastly, there are individuals that when you treat them for regular ADHD don't seem to respond the way we expect them to respond. And those individuals may have complex ADHD, and we have to ask ourselves the reason, what is it about those individuals? What else is going on with them that's making that behavior evident? Now, the goals of the guidelines, and they're clear-cut. The Society for Developmental and Behavioral Pediatrics has some wonderful handouts that they prepared. They prepared handouts for parents and families, prepared handouts for school personnel, prepared handouts for healthcare professionals. And their goals are, if you address the functional impairments when the kids are younger, you can improve the long-term outcome. In other words, before you develop bad habits, if you establish good habits so you avoid bad habits, we hope that they will improve their long-term outcome and become functional adults versus adults that are still negatively affected by their ADHD. Number two, they emphasize the importance of psychosocial treatment. Not just, here's a medicine, now go away because you're fixed, but with the recognition that while medication can improve attention span, it does not teach you how to do things the way you want, and does not teach you the habits that you need, and does not undo the bad habits that you've already developed, but psychosocial treatment being very helpful for that. The goals are that that decisions that are being made is a group effort. It's not just the healthcare professional, it's not just the teacher, it's not just the parent, but it's the team together that includes everyone who's involved, giving feedback, recognizing what is happening, and making sure that things are being implemented in a manner that is best for the affected individual. There should also be coordination of care between professionals. That means if you need to have psychological testing, especially for these more complex things, complex conditions, You may need to have more psychological testing that is done. Has to be done by someone who recognizes, how do I test an individual with ADHD who may have something else present? When I see children in my office, and parents say to me, the school is sending them for testing, and I look at the child and say, this child is not going to sit still. You're not going to get an accurate measure of what's going on. I may start treatment so I can improve their focus so the test results accurately reflect the child's potential and can help guide what needs need to be addressed within the school setting. Also, mental health assessments should be done by individuals who know about ADHD and its differential diagnosis. It has to be, as you mentioned before, multimodal treatment, not only just use of medication, but medication not only for ADHD, but medication for other conditions, behavioral, educational, and other types of interventions for conditions that are associated with ADHD. For instance, one that may be forgotten is the developmental coordination disorder, or problems with fine or gross motor skills that occur in up to 6% of the general population and up to 50% of the pediatric ADHD population. Those individuals, you can put them on medication. It's still not going to make them stellar baseball players. It's not going to necessarily make their handwriting the best it could be. You need further input from the therapist who can help them with these motor skills. I mentioned about psychosocial intervention before, as well as treatment of coexisting conditions. And the goal is we recognize that we're not dealing with them just now at age 4, at age 8, at age 12, at age 16. We're looking at this in a lifespan approach, trying to make sure that their care is going to be addressed irrespective of age. The Society for Developmental and Behavioral Pediatrics committee that put together these guidelines also identified key action points. In other words, what should professionals learn from their guidelines? What should individuals learn from their guidelines? One is the evaluation has to be comprehensive. Number two is when you're evaluating the individuals, you have to use the right tools to evaluate them. If you're going to assess ADHD, use ADHD rating scales. Many people use the Vanderbilt rating scales, but the Connors rating scales and several other ones are out there. If I'm going to assess intelligence, I'm going to do it the right way and not just more of a guess type of a situation. It can confirm existing diagnoses, but it can also identify problems that are present but not really identified. You also have to have interventions to help build their skills. Notice, not medications, but improvement skills. If I have ADHD, my attention span is not that long. How can I function with my attention span not that long, but still be very productive? Things such as breaking things down into smaller units, spending less periods of time to work with small little breaks. All the things that ADHD parents know about this, that professionals know about it, but we're recommending that everyone should become used to it. So it should basically become an automatic behavior when we help these individuals. And when you're going to institute treatments, they should be treatments that are supported by research, not just because I read it on the internet or because my neighbor told me that this works. It should be treatments that are supported by good, solid research. And as I stated before, management over the lifespan, and individuals involved in ADHD care should also advocate to make sure that we address the barriers to care so they're no longer barriers. For families, the goal is that they should have an adequate evaluation, an adequate treatment. That's going to be by the healthcare professional as well as by any psychologist, therapist, or educational personnel. Families need to understand about ADHD. They need to understand what ADHD is all about. CHAD, which is the advocacy group for ADHD, has associated with it the National Resource Center on ADHD, the Centers for Disease Control funded program that is there to provide information and is hosting today's talk. They're a wonderful resource. You have to understand what you're working with so you can basically say, is it the ADHD that's making my child or my spouse or my good friend behave the way he or she is acting, or is it something else? I always tell parents, if it's the ADHD, we intervene. For the kid trying to get away with something, we also appropriately intervene. Families have to ensure that the children get appropriate school services. That's not only in a preschool or regular school year, but going all the way up into college as well as to graduate schools. We should basically have to make sure that there are appropriate adjustments and in the resources that are available at these places to make the individuals successful. And also, one of the big problems we do have is having adequate behavioral interventions. Behavioral interventions in the home, behavioral interventions in the school. Frequently in the school, a behavioral intervention might be leave the room and go to the principal's office. That doesn't solve any problem. We have to have strategies that encourage the behaviors we want, not punish the ones we don't want. Because ADHD individuals being impulsive do not really learn from negative punishment or reinforcement. They learn from encouraging them to do things in a positive way, the positive reinforcement. For educators have to support the assessments that are being done, support families and parents and the individuals that assessments should be done and that programming is available, and should basically make sure they understand how to do it. They should support and be able to successfully implement behavioral interventions in the classroom, and also should work with other professionals, whether it's the healthcare professional, whether it's the therapist or the psychologist, and with the parent in the school years, and with the individual when they're older or when it's a place like the workplace, in order to make sure that the individual can be successful. For healthcare providers, for the primary care providers, pediatricians, family medicine doctors, and I'm going to extend this even to the adult years, to the internists, you have to know who to send the patients to. These are the more complex patients. The simpler ones, we expect them to be able to manage them, because otherwise they're going to overwhelm the resources that we have available to us. But you have to refer to somebody who knows what they're doing. Not just, in my practice, so many times there are those of us who really manage a lot of ADHD and others who don't. You want to make sure you get hooked up with the individuals who know what they're doing in order to maximize the outcome for that individual in a positive manner. Number two is healthcare providers have to make sure that when they evaluate individuals with complex ADHD, that the assessment is comprehensive, that there's input from multiple sources. So you've got basically a wraparound 360 picture of that individual and can make good recommendations as to what that individual's needs are and what interventions would be most helpful. When you're going to do the interventions, we have to make sure the interventions are evidence-based, that the interventions are at that individual's developmental level. So I always laugh when I talk to parents, when I have a 1-year-old in my office, and I ask them, well, tell me how good your 1-year-old is with calculus. And they look at me and said, you're right. They can't do it because that's not a developmentally appropriate expectation we have. Yet we do things similar to that for some of our ADHD individuals. And we have to make sure that what we ask them to do is appropriate, as well as being culturally sensitive, so that it's addressing their needs in a way that the individuals will participate and their families will participate. And again, I'm encouraging the idea. ADHD does not stop at age 16 or 18 years. When I first started in pediatrics, I was told by age 16, 18 years, individuals outgrew ADHD. It made no sense to me, but that's what people said to me, so I didn't have to give them medicine beyond that point. That is not true. As I said, at least half of them continue to be symptomatic and continue to be managed. But we also need additional resources. We need more individuals who are knowledgeable about complex ADHD, and that's the workforce that I'm commenting about, whether it's healthcare providers, educational personnel, counselors, or therapists, as well as having the funding in order to intervene. It costs money to treat these individuals, but there's a payoff, because if we take care of them now, the excess healthcare costs, the lost productivity costs in the adult years, hopefully will not occur. Now, here we go. Here are some of the common conditions when we talk about the comorbidities. This is combined from the American Academy of Pediatrics and the Society for Developmental and Behavioral Pediatrics Guidelines. We're talking about behavioral/mental health disorders, such as underlying anxiety. Now, anxiety can show itself in various ways. You can have individuals with generalized anxiety disorder. Think of it as everything in the world around them stresses them out. You can have individuals with social anxiety, where they're hesitant and stressed beyond belief in interactions with other individuals. You can have specific things or specific topics that can cause anxiety. Obviously, in the very small children, you can have issues such as separation anxiety. But remember, you can have separation anxiety if a child is 7 years old, but mentally at a 3-year-old level. You can also have, in addition to that, things that are no longer classified as anxiety disorders but have associated anxiety, such as obsessive compulsive disorder. Mood disturbances are quite common in this population, both depression when your mood is down, as well as bipolar disorder when the mood is up. And we have to be aware that these conditions may be present in addition to ADHD and may be negatively impacting our ability to manage the ADHD. For an example, a small child who is depressed may not sit still and look lost and forlorn, may be more aggressive and overactive. So if we put them on ADHD medicines, it's not going to fix the problem. You've got to address the mood there. Conduct disorder is basically the equivalent of incipient juvenile delinquency. Basically, individuals who do actions that basically are breaking society's laws and regulations and rules, and those things that we have to deal with, as well as our concerns about substance use. And substance use does not only have to be illicit drugs. It's not only things like the opiates or methamphetamine, but a substance use can also be, if you want to think, it should be expanded. If you think of it this way, cigarette smoking, alcohol use, marijuana, vaping. There's a lot of things that are there that we have to be concerned about that can have negative impacts on your long-term functioning. We also have to think about developmental and educational issues, things that affect learning and language. There's a greater chance of having developmental language disorders in this population, a greater chance of having learning disabilities, whether they're affecting reading, whether they're affecting writing, whether they're affecting math, or whether they're affecting, in addition to that, having problems with what's called the executive functions, which are the brain secretary, how you organize yourself, how you do tasks in a general manner, all of which can really be present. Individuals can also have an underlying autism spectrum disorder. The ADHD may improve, but the ASD, the autism spectrum disorder, may not. And obviously developmental is also the age of presentation that we talked about. There are physical disturbances that can occur in this population. Tic disorders can occur in about 10 to 12% of individuals with ADHD, and we have to recognize what they are, and we have to recognize when intervention is needed. And the reason we have to recognize what they are is because sometimes tics don't occur by themselves. Tics occur in individuals who also have underlying anxiety disorders, underlying obsessive compulsive disorders, all of which may impact the ability to manage ADHD successfully. Individuals with ADHD have a greater risk of problems falling or staying asleep. We call it sleep disturbance. There are some, and they also have there's several reasons. One is they can't wind down. Number two is there's an increased rate of restless legs moving excessively during sleep that can occur in this population. In conjunction with this, another thing that happens, which is not complex ADHD, but we know there's an association, is children with ADHD have a greater chance of being bedwetters, having what we call nocturnal enuresis compared to the general population. And then lastly, as I mentioned, developmental coordination disorders, problems with motor planning, problems with fine motor, gross motor skills, impacting your ability to easily button, easily zip, easily tie your shoes, impacting your handwriting, impacting your ability to do things such as cut your meat when you're eating, to participate in sports activities. And there are remedies and interventions that can be quite successful. Now, the barriers to effective care were addressed both by the American Academy of Pediatrics and Society for Developmental and Behavioral Pediatrics. One is making sure everyone knows what they're doing. Whoever the provider is, whether it's the teacher, whether it's the healthcare provider, whether it's the therapist or the counselor. I have seen children who see therapists who don't recognize that it's ADHD that's going on, and they try to do cognitive therapies that really will not have a positive effect on that individual's functioning. There's also a relative shortage of consultants. We know there's a relative shortage of psychiatrists in the country, child psychiatrists in the country. There's also developmental behavioral pediatricians. There's child neurologists who work in this area. There's general pediatricians who work in this area, in the medical realm. Also for behavioral interventions, in my clinical experience, that's even a greater shortage, being able to find a good resource to help support the parents. Now, for people who want to know some of this, some education about this can also be obtained through CHAD if you access their webpage. And of course, and for teachers, we have to make sure they know what they're doing. In school, there's not a lot of teaching about developmental disabilities, but yet strategies that are effective for helping children with ADHD learn are also effective for helping every child in the classroom learn. Payment for services can be somewhat sketchy with insurance companies, and it's an issue that has to be addressed, as well as payment for care coordination, making sure everyone's doing what they're supposed to be doing. Prescription limitations. The insurance companies basically have preferred drugs that they want you to prescribe, but sometimes those may not work for the child, and then trying to advocate for prescribing something that can be effective can take a long period of time for that healthcare professional, and they may try to dissuade or basically convince them, don't even bother. That's something that we have to make sure that common sense prevails so that individuals can access the medications they need while not necessarily have to pay out the nose in order to get them. Technology can be very helpful in these individuals, but we have to have access to technology. And as I mentioned, caregiver education is very, very important. That's always a rate-limiting step for me, and I encourage all my families to do reading and to access information through the National Resource Center, and here I gave their webpage address. I thank everybody for this, and we still have a few minutes in which I'm happy to answer questions. The bottom line here is the goal of the American Academy of Pediatrics and the Society for Developmental and Behavioral Pediatrics Guidelines for ADHD, whether it's simple ADHD or uncomplicated ADHD or complex ADHD, is to make it easier for individuals with ADHD to develop in the manner to which they should be developing so they can become productive, functional, and happy adults. And I thank you.
The first question that we have is, what works for behavioral therapy in later years that is affordable?
I'm not laughing in a mean sort of way. I'm laughing because I like the terms is affordable. One of the things we have to make sure is that the insurance companies don't put limit as to how many sessions you can have per year, because this is a commitment that's there. The behavioral interventions is parent training. Doesn't matter what age it is, but it's parent training to help the individuals develop positive habits. The interventions for the individuals themselves is basically working on developing positive habit behaviors. In other words, learning to do things in a rote manner so it's automatic. The example I give parents is that when we drive, we very rarely, if ever, pay conscious attention to how we shift our foot from the gas to the brake, when we turn the signals on, when we're turning the steering wheel. It's an automatic thing. We want them to learn these things to be automatic behaviors. So it should be positive strategies that do positive reform. Cognitive behavioral therapy by itself tends not to do much good for you. There are handouts through the National Resource Center that will give you information on those specific topics.
Thank you. The next question is, how does this affect a parent's conversation with a doctor during an evaluation?
The guidelines shouldn't. But remember, what we're doing is we're talking about two things. Most of the time, when parents suspect that an ADHD is present, they're going to go to a primary care provider. All they have to say is, something's going on with a child. We're concerned that it may be ADHD. We would like to have it further evaluated. Or, our child is having learning challenges. Can it be ADHD? That's number one. Number two is being able to say to the primary care provider that are you comfortable with the managing this, or do I need to see someone who is more specialized in this area? We shouldn't say who is more knowledgeable. We'll just say more specialized. That way we don't walk over people's egos. And primary care providers are very good about doing that. In the meantime, the parents should also become educated and do some reading. I don't want to advocate for specific books, although I have my preferences. But there's a lot of good books that are available for parents to learn about ADHD, as well as the parent-to-parent resource that is available through CHAD for education. But that's really what to guide the conversation. The other thing that I have learned in my clinical practice is just describe what the problems are. Don't hold anything back. Many times what happens with me is it's almost like pulling teeth to get some parents to give me the information I need. Just share what's there, share your concerns, put the cards out on the table, spell out the areas of difficulty, and that way you can work together as a team.
Thank you very much. The next question is, can an older teen, like 18 to 20-year-olds, who appeared to have no or few symptoms in elementary school, get an evaluation?
Yeah, the answer is yes. Especially the brighter children may be able to cover up the ADHD features because they're so smart. But what happens is, over time, you find out how inefficient they are in their performance in school. They don't necessarily turn in their work. They have problems completing papers and projects on time. They just aren't. They don't use their time wisely and well. So the proverbial stuff hits the fan at that time. There are certain break points when individuals become symptomatic. The most severely affected ones become symptomatic in the preschool years, and they present as temper tantrums and hyperactivity and lots of figurative head banging with their providers. In the school age years, it's more attention and being fidgety and sometimes also being overactive. In the teenage and adult years, it's just not being efficient. You're not well organized. Your time management isn't good. Things don't get done at the time that they should be. So it's never too late to get an evaluation done. We know many anecdotal stories, both within my clinical practice as well as friends, where individuals were identified in the college years and in the adult years, were successfully treated and literally became superstars in what they were doing.
How should a parent go about finding care when a pediatrician thinks a teen doesn't have ADHD because of his or her age?
If the pediatrician doesn't think that it's present, you can still ask for a referral to a specialist. If you're in a city, a bigger city, there's almost at the children's hospitals, there's always going to be either individuals with ADHD expertise that are identified by the medical center, or they actually have ADHD evaluation clinics. If you think that something like that needs to be done, then access that resource in that regard. Ask other parents in the area. If you're in an area where there's a CHAD chapter, ask within the CHAD chapter who are the individuals in the community who can assess my child to answer my question, yes or no.
In complex ADHD, what should be treated first, the ADHD or the co-occurring condition?
Thank you for that question. I had forgotten to mention that. It's a very simple answer on that one. Whichever one is having the greater negative impact on day-to-day functioning. So let's use a common complex ADHD situation where I got an individual with an anxiety disorder as well as ADHD. If the ADHD is clearly having the bigger impact, you treat the ADHD. If everyone agrees it's the anxiety that's affecting it, you treat the anxiety. Sometimes when you treat the anxiety, you find out that the ADHD basically fades. Sometimes when you treat the ADHD, especially if the anxiety is situation specific, for instance, dealing with learning, school performance, and the school performance improves because of the ADHD, the anxiety drops down. A caveat that's there, and obviously you can't say everything in a talk of this type, or a warning, is that sometimes the ADHD medications can actually aggravate the underlying anxiety. That's something that has to be watched for, and it can be dealt with. There's ways of getting around it. So whichever one is the bigger one, but you have to sometimes sit back and do several trials of interventions before you really hit on the appropriate response.
Here's our final question. How does AAP plan to help improve better reporting with adolescents and their parents?
We can't. If you're talking about reporting of symptoms and signs, it may be if the teenager has a good enough association or rapport with the primary care, with the pediatrician, that the teenager may be honest about what's going on. But even in my own clinical experience, I've had teenagers coming in and, despite overwhelming evidence of their ADHD behaviors, denying that there's anything wrong. And there were some beautiful studies that have been done that show that tends to be the behavior is that we can't change teenage behavior in that regard. What the AAP recommendations, the AAP itself won't do, but the recommendations are to try to work in those areas, identify it, and then slowly but surely get the teenager to recognize that there's an issue there, and or that a trial of medication may be warranted. If you said it, we're going to do it for a specific time period, we're going to see how you do, you're going to give me feedback in terms of yes or no, in addition to what the parents are saying. And most of the time, you can't do it all the time, but most of the time that's successful. My experience in this has been that even if in the teenage years they're not that cooperative, many times as they get older and they get more mature, because remember, ADHD individuals have a lot of social immaturity in comparison to their age-matched peers. But as they get older and into the adult years, they come to the realization, I do need help. And I have had patients of mine who've decided to stop their medications during the teenage years that have, again, restarted them in the college years, and actually have contacted my office directly and said, I need to do something. I recognize what's going on. And the medication, in retrospect, did help did address what I wanted, but I was just too stubborn to acknowledge it.
Thank you very much for this presentation and sharing your expertise with us. And thank you, everybody who has attended today. And I hope everybody has a great afternoon.
And stay safe, please.